We have some questions, so I'm going to read you the first question, and here we go. This is from, let me see here, Dr. Kumar. She wants to know, can you take ACE1s, statin and aspirin at the same time?
Yes, they are all in that category of medications that I call lifesavers. I have a list in my office, it's in every examining room, and it says lifesavers. And I have got them written there. So while the patient's waiting for me to get in there, he knows that if I'm going to save his life, I may be needing one of these medications. So I'm preparing him for that. So yes, aspirin is in the lifesaver category. The other antiplatelet agents, ticagrelor and clopidogrel, are also in the lifesaver category. ACE inhibitors are, but the ARB agents, the angiotensin receptor blocking agents, are also lifesavers with a better risk profile and better tolerability. And then now you have the ARNI, which is angiotensin receptor blocking agent combined with a neprilysin inhibitor, which is even more effective as a lifesaver. And then you got the beta blockers, then you got the statins, and then you got the GL1 agonists for diabetes and or the SGLT2 inhibitors. And these are all in the category of lifesavers. And fortunately, we seem to be able to give them to patients together and actually get not just an additive, but an exponentially increased benefit when we are controlling all these risk factors from multiple angles. It's better to control 4 risk factors 50% than to control 1 risk factor 100%. You get much more benefit.
Well, listen, I mean, that's a great answer. And I'm going to tell you, she has a follow-up to that. She says, should we use only the lowest dose of statin?
Well, I think we are victims of guidelines. Guidelines are guidelines, and they are not telling you how to practice medicine with that patient. They're giving you general guidelines of how you should think in your practice, and then practice medicine based on that patient. So they have research trials, and they looked at people who were on rosuvastatin, and they saw that those who were on 40 and were high risk got actually a significant improvement in their outcomes. And those who are on 80 of atorva got a significant. So that's where those come. They come from thousands of patients in 2 groups of different doses of lipids. And then you are backtracking and then developing thresholds. But for that one patient, it makes no sense to me in medicine to start with the highest dose of a drug like statin, where the response is so extremely variable, and you have a flat dose response curve. It defies all the things I learned in pharmacology.
So that makes total sense. Listen, Dr. Fong wants to know, is there a racial difference in endogenous ApoB levels? And some races genetically higher or lower? Is that a reality, or is that just a suspicion coming from some of the stuff you've been saying today?
It is a reality. I talked about it, and it's really an offshoot of what I presented to you. If you have diabetes, or if you are South Asian, or if you are pre-diabetic, or you are got abdominal obesity, you have more small, dense LDL particles. And therefore, you're going to have a higher number of ApoB when you measure it. And so, yes, there are racial groups that are at higher risk of coronary disease in younger age, such as the South Asians, and they have higher levels of ApoB to begin with, because they have a lot of these small, dense LDL. So really, it isn't the race or the color of the skin itself, but really it is the type of metabolic abnormality you have. The more cardiometabolic disorder your metabolism has, the more your ApoB is going to be.
Dr. Mehra says that the recent Canadian guidelines recommend to check ApoLip A. What's your opinion on that?
Yes, I have a slide, but I'm not going to go to that. It will take time.
Right.
You see, ApoB is a complete indicator of all the atherogenic risk, because every atherogenic particle is attached to ApoB. On the other hand, anything attached to ApoA is non-atherogenic. So if you measure ApoA and you measure ApoB, ApoB over ApoA as a ratio is the best predictor of risk. Because what you're doing is you're making a ratio of all the cholesterol that can harm you versus the cholesterol that cannot harm you. And therefore, you have the most accurate predictor of risk. But if you come to my talk on part 2, you will know that there is no need to measure ApoA for treatment reasons.
That's a great
Just
segue
for
to the
predictor
next
of
topic.
risk. So you have to come to the second talk.
Well, listen, if you folks can't come, I mean, I feel bad for you. I've been listening to a lot of these, and my friend Elnur here, you've done an amazing job tonight. You are captivating, you are clear, and you are a great teacher. I'm saying this without trying to butter you up, because you don't owe me money and we're not related. So there you go.
Thank you so much. You're being very kind. You know, all the effort I put into accumulating the data, this is what makes it worthwhile, that I can transfer the knowledge.
Anybody else have a question before we shut us down for the night? You can open your mics up if you like and ask the question.
Dr. Elnur,
Yes.
according to British recommendations, that was about 2 years ago. They say all the South Asians, they should have a ApoA. But what is the, you said the ratio is more important. So where does the ratio stand? At what level the ratio is more at high risk than the low risk?
Okay. You see, the problem is that the risk calculators do not have skin color in it. So there is no way you can put how dark the skin color of that patient is to calculate risk. And we know that certain people with darker skin have higher risk, but that's due to the metabolism inside, all right? So now we can't then really estimate the risk of a South Asian, because we are underestimating it, because there is the added genetic risk and there is the added lifestyle risk in South Asians, which increases their coronary event rate and makes their coronary events come 10 years earlier and cause more mortality and respond poorer to therapy. So if you measure ApoA and ApoB, then in that South Asian, you have used a more predictive measure of his risk. Not that the ApoA is anything specific to do with the South Asian. It is just as accurate in a white person as it would be in a South Asian as a risk predictor. All right. And you remember the Interheart study, which was done across the world, which finally absolutely made us realize that when a patient is admitted into hospital with a first heart attack, what are the things that are more prevalent in that patient versus the other patient who is matched at the same time in the hospital who has not had a heart attack? And the thing that was the highest predictor of a first heart attack was the ratio of ApoB to ApoA. So it is a risk predictor. And if you ask me the number, I can't tell you, because I very rarely order ApoA.
Thank you. Thanks very much.